Thanks so much, Amy. Thanks to everyone. Thanks to Ana Diaz-Rux for inviting me. Thank you to all the presenters today. It's been really interesting, and I've enjoyed everything I've seen so far. I really especially enjoyed Martin's presentation earlier, and I appreciate the introduction to systems and to system science and systems thinking. I'm going to talk a little bit about systems thinking and why we need it, a very little bit about a review project, a systematic review we're trying to do about systems approaches in urban health research. And I want to start by acknowledging my co-authors who've put in a tremendous amount of work on this. Eileen Spicer and Janice Alvey at UNC Chapel Hill, Sarosh Jayasinghe at the University of Colombo in Sri Lanka, Crystal Donnelly at Imperial College London. And I should also say that the work here really emerged from discussions and from the thinking of the Science Committee for the ICSU program on urban health, which I'm going to mention at the end of this talk. Now, just to start with some background, you're all familiar with figures like this. I think it's good to revisit them. In the century between 1950 and 2050, the Earth's population will have much more than tripled. The percentage of people living in urban areas will have risen from less than 1 in 5 to about 2/3. We passed the point when most people live in cities sometime around 2008, 2007, I think Martin said. There's some dispute about the exact date. Asia, which has the highest population of any region, will pass it sometime in the next decade. Now, this is a tremendous change in the way that we live. It's essentially irreversible as well. For tens of thousands of years, modern humans have evolved to live in small communities, to live amidst nature, and we've shifted everything in just a very short time. In a sense, the last century or two is sort of a huge experiment in habitat change for humanity. Most of us are really familiar with the previous figure, but not as many people appreciate the scale of the expansion that's going to be required to house all these new urbanites. We're going to add about 2 billion people to cities by 2050. There's essentially all new population growth globally over that time. This translates to about 1 million people every week moving to cities. That's about the population of Philadelphia every 10 days. It's been estimated that of all the urban land that will exist in 2030, 65% of it will have become urban after the year 2000. So we've been building cities for maybe 6,000 years, depends how you want to define cities. But 6,000 years, over all that time, they've grown more complex and bigger and expanded and covered more and more of the earth. And in this period here at the end, which is drawn to scale, we're going to just about triple what we've had before that. So for basically, for every city that exists right now, this is, I believe, London, and that's Medellin, Colombia, and New York, we're going to add the equivalent of another and about 80% more in one generation. I have a few pictures that show the beginning of this transition and just how startling it is. This is Kuala Lumpur, where I live, where the UNU International Institute for Global Health is. This is in 1990 and 2014, about a quarter century later. The people living in these two cities have profoundly different lives, right? They live in different kinds of buildings, they shop in different kinds of stores for different things, they have different problems trying to get to work. They have different standards of living, different ways of communicating, they eat different food, exposed to different air, they see different amounts of the color green. I should say the quality of the 1990 pictures substantially worse, but I'm pretty sure the air pollution's worse now. This is Shanghai, where the change has been even more dramatic. This is happening all over eastern China. In fact, China just recently, I think the last month or two, announced plans to join up Beijing and Tianjin and Hebei into one giant city. This is going to be a city with about 145 million people, connected by high-speed rail, zoned so that different parts do different things. It's going to be about the size of Kansas. And without singling out China, I think it's fair to sort of speculate as to whether we're ready, whether our governance and management systems are ready for this kind of thing. I think it's also fair to say that maybe we're not. Although it's interesting, some of the things that Martin presented, maybe we are ready. We'll have to think about that. This is Dubai, and in some ways this is the most startling of these pictures. Dubai was basically a city in the desert, a little town in the desert 25 years ago. Now it's a towering metropolis. The point of these pictures is that urban changes have been transformational of the Earth, but of our lives as well. They'll continue to be so for at least the next few decades. Given how drastically they modify people's lives and environments, it would be completely surprising if these changes weren't linked to health outcomes. And in fact, of course, they are. So we know that even though there are some very large and in some cases growing inequities, health is usually better in urban areas than in rural. And still, we see all of these health problems which resist our efforts at control or resolution. In some of these cases, like for air pollution or tobacco use, these are old problems arising in new contexts, almost like a basic feature of urban development. That's Leeds in the early 20th century, and this is, I believe, Beijing. It might be Shanghai today. I think it's Beijing. So, we'd like to tell cities, this is how you skip these things. Sort of the way that people in developing countries are skipping landlines and moving to cell phone uses. But there are other challenges in these areas that make that difficult. Others of these problems, like, for example, the global epidemic of obesity and overweight, are relatively new, and nobody's figured out how to address them. So there's a Lancet study last year that showed that of 180 countries in the world, not one of them has reduced the obesity rate in the last 30 years. And that seems a little bit crazy. I mean, we have decades of research on obesity. We have centuries of experience in managing cities. So why are we having so much trouble? My institute and others would argue that what these and other urban health problems have in common is complexity. And that's a consequence of the fabric of cities, the nature of these problems themselves. More specifically, these problems have characteristics of systems problems. They're resistant to change. The actions we take often don't have the effects that we expect, or they have the opposite effect. So, we have too much traffic, so we build more roads, and we end up with more traffic. We prescribe antibiotics to resolve some infectious disease problem. We end up not only with that infectious disease problem, but also antibiotics that don't work. These problems have complex determinants. They usually require multiple simultaneous interventions, and they're potentially affected by the actions of many different actors at different scales. Usually they're related to other problems as well, and often they're connected in feedback loops. So what? I mean, so they have these characteristics. Why are they so hard to address? One reason is complexity itself. So if you imagine that you have a crank attached to a machine with a couple of gears in it, if there's one or two gears, you can probably pretty easily figure out how they're going to move when you crank the crank. But if you put in 100 gears, it becomes almost impossible. So that's a simple deterministic system, but it has just one input, no random variation, and no feedbacks. So complexity itself can make it very difficult to understand what's happening. Another reason is that there's a very high degree of specialization, both in academics and in urban management. We live in these very siloed intellectual worlds. We're trained in certain ways of thinking. We interact with other people who are also trained that way, and they reinforce our thinking. And we tend to tackle certain, well-defined kinds of problems. But when the real problem in the real world spans 2 or 3 or 15 or 20 sectors, it becomes almost impossible to perceive it, much less address it. And of course, actions in our own sectors have consequences in other sectors. Garrett Norden, an ecologist, said, you can't do only one thing. And that's true in cities. Anything you do has many, many different consequences. Now, a third reason which flows from this is that we're trained to be reductive in our thinking. We try to find the effect of risk factor A on outcome B, controlling for all confounders. We talked about this a little bit before in the presentation on natural experiments. And this is important. We need to know the effect of outcome A, of risk factor A on outcome B. It's necessary for scientific understanding, but even though it's necessary, it's not sufficient. So I can know that relationship, but still not know what's going to happen in the real world when I push on variable A. You can specify all the links between variables in a system and still not be able to understand the behavior of the system. So there's a growing recognition that we need to go beyond the traditional methods and to embrace systems approaches. There's a lot of differences in terminology around systems. But essentially, when we're talking about this, we mean two related tasks. The first is you need analytic methods that can capture this complexity, that can understand how a system will evolve over time in response to various inputs and actions. So if you push on this lever, how does the whole thing evolve? Second, you need a set of focused interactions or dialogues. You need this between different kinds of scientists, between scientists and decision makers, and between both scientists and decision makers and communities. And the second part, it's partly normative. You want to include people, you want them to be involved in securing their health, but it's also absolutely necessary to define problems adequately and to look for solutions. To address obesity, you need public health people, you need clinicians, but you also have to have city planners, you have to have transport engineers, parks and recreation managers, and citizens. So we're working on the systematic review, and the goal of it is basically to understand to what extent these kinds of approaches are already being used in the context of urban health, and to suggest where there are opportunities to do more. We looked at articles published in English from 2000 to 2014. We used keywords about cities, about a particular set of analytic systems tools, and about health. Now, we focused on the methods side of systems approaches because it's much harder to assess the dialogue aspects. When people publish papers, they may mention the extent to which they're interdisciplinary, but they probably don't. They may mention whether they engaged with stakeholders, but only if that's their really primary focus. So it's hard to assess that. So we look at the methods. There's also a lot of different modeling approaches that would sort of fit the criterion. So we had to focus down, and our sort of touchstone, our central criterion, was whether the method that was used would be able to capture dynamic feedbacks. And so we're looking at things like systems dynamics models, agent-based models, individual-based models, cellular automaton, things like that. We looked for studies where the city played a central role in the problem, so rather than just being the study site for the study. We did have a few important limitations. One is that there's quite a large literature that uses systems methods to think about optimizing health services in hospitals, for example. And so we're more interested in interventions that sort of transcend the health sector, so we didn't look at those studies. The second is, and this is an important one, that we focused on studies that look at concrete health outcomes rather than health-related behaviors. And that's an important distinction, but the truth is that most behaviors have health effects, and the search was a lot more complicated, and the subjectivity was a lot higher if we included those. But we have noted those studies, and we have them, so it may be that we decide to tackle them afterwards. Lastly, we tried to focus on studies that have an applied component, that are actually focusing on a problem in the real world rather than those that are essentially mathematical studies. And there was some subjectivity there because a lot of studies try to be mathematical but then also try and demonstrate it with something in the real world. But what can you do? So we're recording a pretty wide set of variables that characterize the methods and goals of the study, how accessible it is or might be to researchers or lay people who want to either replicate it, take it further, or use it for themselves, and to whatever extent possible, whether it addresses some of the other aspects of systems approaches as we sort of define them. I won't say too much about this, but I'll give you a couple seconds to look at it if you want. Now, I won't go through this in too much detail, but we started with about 1,100 unique records from our search, so it was quite a task to narrow them down. We got down to about 70 studies, which fit all the criteria, and we probably have about the same number of behavioral outcome studies. I don't know the specific number, but those are out there. Now, what we found was, in terms of geographies at least, was a reasonably good distribution of studies by region. The development world does count for about 2/3 of these, but we got more than we expected from the developing world, excuse me. These are parceled out by the type of health outcome they address. So you have acute respiratory infections and TB, STDs, vector-borne and vaccine-preventable disease, and other. And of course, The other includes NCDs, injuries, asthma, rabies, oral health, a couple of other things. But the fact that I've put it in the other sort of tells you the main outcome of the study. The most striking thing is that almost all of this is infectious disease. And that's not too surprising. There's a long history of modeling infectious disease. You can go all the way back to Ronald Ross's malaria models at the beginning of the 20th century. And so systems methods sort of naturally flow from that background. And in fact, in most of those studies, the feedbacks are really part of the transmission system rather than of the social ecological system, which is what we're more interested in. Though there are a few interesting pieces on how people's behavior changes, for example, in response to epidemics. The more interesting studies, in a way, are those that try and look at non-infectious disease problems, but there's room for a lot more work in that area, clearly. We saw that there are sort of regional foci of attention. The majority of the Latin American studies are on dengue. Most of the African ones are on STDs. Most of the East Asian ones are on influenza or SARS. And in some sense, this sort of reflects what you'd expect as regional interests, but it also suggests that, that research in these areas is sort of still dominated by just a few research groups interacting with one another. And so we have to see how we can expand that. This will be out fairly soon, maybe by the end of the year. It's a characterization of a quite circumscribed slice of what's going on in this area, but maybe it's of use, and we hope it's of use. We know that there are lots of urban decisions that are guided by models and sort of systems thinking that aren't published, and we'd like to find a way to access those kinds of stories. Of course, we're also, as I said, thinking about how to work with some of the other studies on behavioral outcomes and so on and so forth. And on that note, I'm very interested to hear some of the presentations by my co-presenters who I know are looking at those issues. So I'm just going to close with a few words about this program. This is a new global science program on systems thinking about urban health. It's sponsored by ICSU, which is the International Council for Science, which is a venerable science program that sort of represents the scientific community in the UN and in other things. And part of its job is to draw together scientific programs where it sees need for coordination at the global level. This is ICSU's first program on human health. It's co-sponsored by my institute, the United Nations University, and by the Inter-Academy Medical Panel. It was launched last December in Xiamen, China, at the Chinese Academy of Sciences Institute of Urban Environment. And over the next decade, we hope that it will play a major role in promoting and integrating this kind of research, increasing the amount of funding available at a global scale and to people who are interested in doing this kind of work, raising the visibility of studies in this area, and identifying gaps in knowledge and sort of targets of opportunity. I'm happy to say that Anna is on the science committee for the program, and so there's a natural connection with Drexel. Now, the director was going to be here today. Franz was going to present in our session, but unfortunately he hasn't been able to come. So I am happy to be a proxy, and if any of you are interested, I'm happy to talk about it. So that's about it, and thank you very much.